I'm about to reveal something that might completely change how you think about exercise and your heart. Something about the advice that has been given to seniors with high blood pressure for the last 40 years. The instruction you've heard from every doctor, every health segment, every pamphlet in every waiting room. Get out and walk. Get your heart rate up. 150 minutes of aerobic cardio every week. What I'm about to share goes against everything you've been told about what your cardiovascular system actually needs. Most cardiologists are not aware of this data yet because it comes from a meta-analysis published in July of 2023 that reviewed 270 randomized controlled trials and reached a conclusion that turns the entire exercise prescription for seniors completely upside down. But here is the part that will shock you most. For the millions of seniors who push through joint pain to get those walking minutes in, grinding bone on bone, fighting through the hip and knee pain to do what they were told was good for their heart, the biochemistry of what that pain is doing to your blood pressure is the opposite of what you think. You may be chemically locking your own blood pressure higher every time you take that walk, and nobody told you. By the end of this video, you will understand exactly why aerobic exercise fails so many seniors with joint pain, what a 10-minute daily habit involving nothing more than a rolled-up towel or a chair against a wall does to your cardiovascular system at the cellular level, and why the research now shows this single habit matches the blood pressure reduction of a primary prescription medication. This is not about doing less. This is about doing the right thing. Stay with me, because what you're about to learn could literally change everything. And it starts with a man named Gerald. Gerald was 72 years old. He lived in Portland, Oregon. He had been a high school football coach for 28 years, which meant his relationship to exercise and physical effort was not one of avoidance. He had believed in movement his entire adult life. He had coached young men through the value of discipline and consistent physical work, and he had applied those same values to himself in retirement. When his cardiologist told him he needed 150 minutes of moderate aerobic exercise every week, Gerald did not question it. He bought good walking shoes. He mapped a 3-mile route through his neighborhood. He walked it 6 days a week without fail. His blood pressure was 158/94. It had been in that range for 3 years. He had started the walking regimen specifically to bring it down. He was doing everything he was told. More, actually. He was walking more days per week than his cardiologist had suggested, covering more distance, staying consistent through weather that would have kept most people inside. He tracked his steps. He logged his walks. He approached it the way he had approached coaching, with structure, discipline, and data. His knees were destroying him. He had bilateral osteoarthritis diagnosed 6 years earlier. His orthopedist had told him at the time that the cartilage was significantly degraded in both knees, bone on bone in the right, approaching it in the left. He had been managing with ibuprofen and stoicism, neither of which he would mention unless directly asked. He did not limp during his walks because he had spent a career teaching young men that you do not limp. He finished the 3 miles regardless of what it cost him. He considered this admirable. He was wrong about what it was doing to his blood pressure. His wife Diane had watched him ice his knees every evening for 2 years. He did it without complaint, the way he did most things, efficiently, without drawing attention to the effort. He would sit in the recliner after dinner with 2 ice packs wrapped in dish towels on his knees, reading or watching the news. And when 30 minutes had passed, he would unwrap them and fold the towels and put them back in the kitchen and say nothing about it. Diane had asked once, in the first year, whether the walking was making the knees worse. Gerald said the cardiologist said to walk. She did not ask again. She noticed, though, that he stood up from chairs differently than he used to. The pause before rising, the slight bracing, the way he held the armrest not casually but deliberately, taking weight off the knees for the fraction of a second before the legs came underneath him. She knew that by the end of a 3-mile walk, he was managing the pain actively. She could hear it in the evenings in the slight thinning of his voice when he was standing. But he had a lifetime's practice of not showing effort, and she had a lifetime's practice of respecting that. What neither of them knew, because nobody had connected these things, was that the ibuprofen Gerald was taking to manage the knee pain was also affecting his blood pressure. NSAIDs suppress the prostaglandins that the kidneys use to regulate sodium excretion. Gerald was taking ibuprofen to manage the inflammation caused by the walking that was supposed to lower his blood pressure, and the ibuprofen was pharmacologically working against his blood pressure medication. 3 interventions stacked against each other: the inflammatory cytokines from the joint grinding, the cortisol from the chronic pain signal, and the renal sodium retention from the ibuprofen, all of them pushing the same direction, all of them invisible on the 10 a.m. cuff. Here is the mechanism that nobody explained to Gerald, and that most doctors who recommend walking to seniors with joint pain do not fully understand. When a degraded joint, bone grinding on reduced cartilage, is put under repetitive mechanical load, the joint releases biochemical distress signals into the body. Not mild signals, not localized signals. Systemic inflammatory molecules that flood the bloodstream within minutes of the mechanical grinding beginning. 3 of them matter specifically for blood pressure: interleukin-6, tumor necrosis factor alpha, and substance P. Interleukin-6 and TNF-alpha are pro-inflammatory cytokines. In the quantities released by a joint undergoing repetitive mechanical stress, they circulate through the bloodstream and physically damage the endothelial lining of the blood vessels, the same thin inner wall that produces nitric oxide and determines whether your arteries can dilate and lower pressure. When IL-6 and TNF-alpha are elevated chronically, that endothelial lining is inflamed and functionally impaired. The blood vessels cannot dilate properly regardless of what other interventions are in place. Substance P is the primary neurotransmitter of chronic pain. Its job is to carry the pain signal from the joint to the brain. But substance P also activates the HPA axis, the hypothalamic pituitary adrenal circuit that controls the stress hormone cortisol. Chronic pain is, biochemically, chronic stress. The body cannot distinguish between the pain of damaged cartilage and the threat of a predator. Both activate the same ancient alarm system. Cortisol floods the system. The sympathetic nervous system locks into a low-grade fight-or-flight state. The blood vessels become hypersensitive to adrenaline and stay constricted. Gerald walked 3 miles 6 days a week. Every step mechanically loaded his degraded right knee. Every step released IL-6, TNF-alpha, and substance P into his bloodstream. Every walk inflamed his endothelial lining, activated his HPA axis, and chemically forced his blood vessels to stay constricted. The exercise that was supposed to lower his blood pressure was producing a biochemical environment that made lower blood pressure impossible. He was, faithfully and diligently, undoing the intervention at the source. I want to make this mechanism viscerally specific, because most people hear the phrase inflammatory molecules and process it abstractly. What interleukin-6 and TNF-alpha actually do to the endothelial lining is not abstract. The endothelial cells that line the inner wall of every blood vessel are not passive. They are active, sensitive, and responsive. They produce nitric oxide continuously in response to blood flow. They regulate which molecules pass from the bloodstream into the surrounding tissue. They signal the smooth muscle layer surrounding the vessel to contract or relax based on the conditions they detect. When they are functioning correctly, they are one of the primary regulators of blood pressure. When IL-6 and TNF-alpha flood the system at the concentrations produced by a joint undergoing repetitive mechanical grinding, they activate the endothelial cells' inflammatory signaling pathways. The cells shift from their normal regulatory function into an inflammatory state. They begin producing adhesion molecules that attract immune cells. They reduce their nitric oxide output. They increase their production of endothelin-1, a potent vasoconstrictor. The vessels, under the influence of systemic inflammation, are pulled toward constriction by the chemistry of their own lining. A senior whose blood pressure is 158/94 after 3 miles of walking is not simply failing to exercise enough. Their endothelial lining is chemically in an inflammatory state for hours after every walk, producing vasoconstriction rather than vasodilation. The medication prescribed to lower their blood pressure is competing with the biochemical output of their own damaged joints. Gerald's cardiologist was watching a number that refused to move without understanding that the treatment being applied to lower it was biochemically working against it every single morning. His blood pressure was 158/94 after 3 years of 6-day-per-week walking because he was fighting his own inflammation every single morning. Gerald's situation is not unusual. It is the norm for a specific and very large group of seniors, the ones who exercise faithfully, whose labs come back normal, and whose blood pressure does not move. The doctor sees the compliance and increases the medication dose. The senior walks harder and longer. The inflammation compounds. The readings stay fixed. The reason this pattern persists is that the cardiology recommendation, 150 minutes of moderate aerobic exercise weekly, was developed without stratifying the population it was being applied to. It was based on evidence from studies of people with functional joints who could perform aerobic exercise without triggering a significant inflammatory response. Applied to a 65-year-old with bone-on-bone osteoarthritis, the recommendation produces exactly the opposite of its intended effect. The walking does not lower blood pressure in this population because the walking is generating the biochemical environment that prevents blood pressure from lowering. This is not a reason to distrust medicine. It is a reason to bring specific information to specific conversations. Gerald's cardiologist knew the standard recommendation worked for most patients. She did not have the 2023 data integrated into her protocol. When Gerald brought it, when he named the mechanism and cited the trial, she reviewed it and changed her recommendation for his specific profile. That is how medicine is supposed to work. Patient and physician together, updating the approach when better information is available. Now let me tell you what the British Journal of Sports Medicine published in July 2023, because this is the data that changes everything. Researchers conducted a meta-analysis, a systematic review of existing research, covering 270 randomized controlled trials with over 15,000 patients. They compared every major category of exercise for blood pressure reduction: aerobic walking, high-intensity interval training, dynamic weightlifting, and isometric exercise. Isometric exercise means contracting a muscle and holding it completely still under tension without moving the joint at all. No walking, no repetitions, no joint movement of any kind. The results were unequivocal. Isometric exercise was superior to every other form of exercise for reducing resting blood pressure. Not modestly superior, significantly. A 10-minute daily isometric habit lowered systolic blood pressure by an average of 8.24 millimeters of mercury. To put that number in clinical context, that is the equivalent of the blood pressure reduction produced by a primary prescription antihypertensive medication. The same result, without a pill, without joint impact, in 10 minutes. Gerald's cardiologist had never mentioned isometric exercise. Not because the research did not exist. The body of evidence for isometric exercise and blood pressure has been building for over a decade. Because the conversation in cardiology has been aerobic exercise for so long that most practitioners are not yet integrating the 2023 data into their standard recommendations. This is not negligence. It is the lag between research and clinical implementation that exists in every field of medicine. Gerald did not know this existed, and so he kept walking on his destroyed knees, doing precisely the wrong thing, diligently and with discipline, for 3 years. Before I explain why isometric exercise works, and the mechanism is remarkable, one of the most elegant pieces of vascular biology I have ever translated for a patient, I want to say something directly to anyone who recognized themselves in Gerald's story. The protocol that gets your blood pressure moving when walking has failed you is in the description below. Not a diet program, not a supplement stack. A 10-minute daily protocol built specifically for seniors that addresses the cardiovascular system at the cellular level. The link is there. Now, why does it work? There are 5 separate biological mechanisms, and understanding each one will make the protocol feel like the precise, targeted medical intervention it actually is. The first mechanism starts with what happens inside the muscle during the hold. When a muscle performs a dynamic movement, the alternating contraction and relaxation of walking, for instance, blood flows in and out continuously. Fresh oxygen arrives, waste products leave. The circulation is unimpeded. But when a muscle performs an isometric hold, squeezing a hand grip, holding a position against a wall, the muscle fibers contract and remain contracted. The sustained tension causes the muscle fibers to bulge and thicken, physically compressing the microscopic blood vessels woven through the muscle tissue. The compression acts like a tourniquet applied from the inside. Local blood flow stops. The muscle cells, cut off from fresh oxygen, begin burning through their stored ATP, the cellular energy currency, at an accelerating rate. As ATP breaks down, it produces waste products, including lactic acid, hydrogen ions, and a molecule called adenosine. Within 60 to 90 seconds of the hold beginning, adenosine is flooding the extracellular space around the compressed vessels. Adenosine binds to specific receptors on the smooth muscle of the vessel wall, the A2A receptors, and begins commanding those vessels to prepare for maximum dilation the moment the compression releases. This localized oxygen starvation is called targeted ischemia. It is deliberate, controlled, and specific. No other tissue is affected. No joint is loaded. No inflammatory cascade is triggered. Just a small, targeted zone of muscle tissue briefly and safely starved of oxygen, building up the biochemical pressure for what comes next. The second mechanism is what makes cardiologists who understand this data call the reactive hyperemia response one of the most powerful, non-pharmacological cardiovascular interventions available. When the 2-minute hold ends and the senior releases the contraction, the physical compression inside the muscle vanishes instantly. The vessels, flooded with adenosine commanding maximum dilation, open to their widest possible diameter. And because the local tissues are oxygen depleted, the body rushes blood back into the muscle at 4 to 5 times the normal resting volume. This sudden, massive return of blood is called reactive hyperemia. Think of it as the biochemical equivalent of a dam releasing. The blood rushing back through the vessels creates intense physical friction against the inner wall of the artery, specifically against microscopic hair-like structures called the endothelial glycocalyx that line the vessel wall. These structures bend violently under the sheer stress of the returning blood surge. The bending triggers a massive influx of calcium into the endothelial cells. That calcium activates dormant enos enzymes, the same endothelial nitric oxide synthase that uric acid silences and that the entire nitric oxide system depends on. The activated enos dumps a concentrated surge of nitric oxide directly into the surrounding smooth muscle. That nitric oxide surge does not stay local. It signals the smooth muscle throughout the cardiovascular system to reduce its resistance. Blood pressure drops, not just in the exercised muscle, but systemically. The entire vascular grid relaxes in response to the signal generated by a 2-minute hold in a single muscle group. This is the mechanism behind the 8.24 millimeter reduction in the British Journal of Sports Medicine data. Not sustained effort, not elevated heart rate. A controlled ischemia followed by a reactive hyperemia followed by a nitric oxide surge. 4 times, 10 minutes. The third mechanism is the one with the most profound long-term implications, and it requires understanding what happens to blood vessels as we age. Capillary rarefaction is the medical term for something that happens silently in every sedentary aging body. The gradual death and disappearance of microscopic blood vessels in the muscle beds. These capillaries, the smallest vessels in the circulatory system, supply oxygen and nutrients to the tissues they serve. When they disappear, the tissue loses perfusion capacity. The larger arteries upstream must compensate by increasing pressure to force adequate blood flow through a reduced network. If the cardiovascular system is a city's water distribution grid, capillary rarefaction is the equivalent of eliminating 30% of the neighborhood pipes, while keeping the same volume of water moving. The pressure in the main lines has to go up. Isometric exercise reverses this process through a protein called HIF-1 alpha, hypoxia-inducible factor 1 alpha. When the muscle is starved of oxygen during the 2-minute hold, HIF-1 alpha is activated like a biological distress signal. It instructs the body to secrete VEGF, vascular endothelial growth factor, which acts as a chemical blueprint for new blood vessel construction. The body responds by physically growing new capillaries in the exercised muscle. This process is called angiogenesis. By performing the 10-minute hold protocol daily, a senior is triggering VEGF release daily. The capillary bed in the exercised muscles expands. New microscopic pipes are built. The plumbing grid becomes larger. The pressure in the main lines can drop because the downstream network has more capacity to receive the blood. This is a structural change, a permanent modification of the cardiovascular architecture, not a temporary dilation, not a drug effect that wears off. New vessels, physically grown in response to the daily ischemic signal. The clinical implications of angiogenesis extend beyond blood pressure in a way worth understanding clearly. Capillary rarefaction is not only a blood pressure problem. When the microscopic vessels disappear from muscle tissue, the muscles themselves become less efficient. They fatigue faster, recover more slowly, and respond less effectively to any form of exercise. Seniors with significant capillary rarefaction find that physical activity that should be manageable is exhausting out of proportion to the effort involved. They attribute this to age. Age is partially the answer. The loss of capillary density is the rest of it. Isometric exercise is one of the few interventions that directly reverses this process in adults over 65. The HIF-1 alpha pathway, the one triggered by the 2-minute ischemic hold, is the same pathway that is active during fetal development when the body is building its initial capillary networks. The body retains this capability throughout life, but has no reason to activate it unless the ischemic signal is present. Sedentary aging never provides the signal. The capillary network slowly contracts. The protocol provides the signal daily. The network begins to rebuild. The timeline for meaningful angiogenesis is 4 to 8 weeks with daily activation. This is why the 6-week threshold in the research corresponds to the most significant blood pressure reductions. By week 6, the capillary expansion is functional enough to produce a measurable change in systemic resistance. The enos upregulation contributes from week 1. The angiogenesis contributes fully from week 5 or 6. Gerald's week 3 improvement was primarily enos upregulation. His week 6 improvement included the beginning of angiogenesis. These are different biological events, running on different timelines, compounding each other. There is a further implication that I want to name directly, because it is extraordinary. These newly grown vessels do not only serve blood pressure management. If a major artery is ever partially blocked by plaque later in life, the collateral circulation that the isometric habit has been building for months or years provides biological bypass routes, alternative pathways for blood flow that preserve tissue downstream from the blockage. Nature's bypass surgery, built over time. From a recliner. The fourth mechanism addresses why seniors with essential hypertension, the pattern we discussed in the previous video, are trapped in a state of chronic sympathetic nervous system dominance, and how isometric exercise specifically interrupts that pattern. During the 2-minute hold, the brain detects the sustained muscle tension and the accumulating lactic acid. It responds with what is called the muscle pressor reflex, a temporary elevation of heart rate and blood pressure as the body attempts to force blood into the compressed muscle. Blood pressure and heart rate spike modestly during the hold. This feels uncomfortable. It should. It is supposed to. The moment the hold is released, the tension vanishes. The lactic acid signal stops. The muscle pressor reflex turns off. And because the contrast between the tension state and the release state is sharp and complete, the brain registers a profound return to physical safety. It does not taper off gradually. It stops. That sharp contrast triggers a massive activation of the vagus nerve, the parasympathetic system, the rest and digest circuit that is the biological opposite of fight or flight. The body swings hard in the parasympathetic direction in response to the sudden release from tension. By performing 4 holds with 1-minute rest periods, the senior is performing 4 repetitions of this autonomic swing, 4 cycles of deliberate sympathetic activation followed by deliberate parasympathetic rebound. Over 6 weeks of daily repetition, this trains the brainstem to lower its baseline sympathetic tone. The chronic adrenaline signal that keeps essential hypertension locked in place begins to quiet. The body learns, at the neural circuit level, that it can safely relax. Not because anything was prescribed, because the resting state was trained through repetition. The fifth mechanism is one that elite cardiac surgeons use in the operating room, and that most people have never heard discussed in the context of daily self-care. Before major open heart surgery, some cardiologists inflate a blood pressure cuff on the patient's arm to temporarily cut off circulation, then release it. They do this deliberately, before the cardiac intervention begins. This is called ischemic preconditioning. When a tissue is briefly starved of oxygen and then resupplied, the body releases protective molecules, bradykinin, endogenous opioids, and specific cardiac protective proteins that travel through the bloodstream to the heart muscle. These molecules open specialized channels in the mitochondria of the cardiac cells, altering the cellular metabolism in a way that makes those cells significantly more resistant to oxygen deprivation. Cardiac surgeons use this technique to make the heart more survivable under the extreme ischemic conditions of open heart surgery. When a senior performs a 10-minute isometric hold protocol daily, they are self-administering ischemic preconditioning to their cardiovascular system. The brief oxygen starvation of the muscle, followed by reperfusion, releases the same protective molecules. The same cardiac protective signaling occurs. The same mitochondrial channels open in the heart cells. Day after day, the cardiac muscle is being biochemically conditioned to withstand oxygen deprivation. If a heart attack or stroke occurs years later, the cardiac and brain cells that have been daily preconditioned will survive significantly longer on reduced oxygen than cells that have never received this signal. What makes ischemic preconditioning remarkable as a concept, and why it belongs in this conversation, is what it reveals about the body's capacity for preparation. The cardiac cells are not fixed in their resilience. They can be conditioned. The mitochondria, which are the energy-producing organelles inside each cell, respond to repeated ischemia-reperfusion cycles by changing their internal chemistry. The cells become, literally, more robust, more capable of surviving the conditions that kill unprepared cells. Cardiac surgeons use a version of this deliberately because they know they are about to subject the heart to severe ischemia during the procedure. They precondition the heart first to reduce the cell death that follows. A senior doing 10 minutes of isometric holds each morning is not doing something surgeons invented. They are activating a biological capability that has always existed: the body's ability to prepare its own cells for ischemic challenge through repeated, controlled, mild ischemic exposure. The surgery uses it acutely. The protocol uses it cumulatively. Both activate the same mitochondrial pathways. A senior doing 10 minutes of isometric holds every morning is not just lowering their blood pressure today. They are making their heart more biologically durable for whatever comes next. Let me tell you about a woman named Patricia to make the wall-sit modification concrete and to show you what this protocol looks like in a body with a different history than Gerald's. Patricia was 69 years old. She lived outside Nashville, Tennessee, and had been a nurse for 31 years before retiring. She did not have osteoarthritis, but she had a different problem. Her resting blood pressure was 161/96, and she had a pacemaker. Her cardiologist had been cautious about exercise recommendations because of the pacemaker, and Patricia had largely stopped structured exercise in the 2 years since its implantation. She walked short distances but had become sedentary in a way that troubled her and that she knew was not helping. She was also, by her own description, someone who needed to understand why something worked before she would trust it enough to do it consistently. 31 years of nursing had given her that disposition. She did not follow instructions she did not understand. When she read about the 2023 British Journal meta-analysis and the 5 mechanisms, she sat with the research for 3 days before starting. She wanted to understand the reactive hyperemia mechanism in detail before she was willing to create deliberate ischemia in her own body. When she was satisfied that the protocol was safe for someone with a pacemaker, she confirmed this specifically with her cardiologist, who reviewed the research and approved it. She started with the modified wall sit. She stood with her back flat against her kitchen wall, feet stepped forward until her knees were directly above her ankles. She slid down until her thighs were at roughly 45 degrees. Not 90, 45. Her knees were comfortable. There was no joint pressure, no grinding, no patella compression. The engagement was entirely in the large quadriceps muscles, a deep, sustained burn that built slowly through the first 90 seconds and became genuinely demanding by the 2-minute mark. She breathed through pursed lips from the start. She had administered enough medications and seen enough Valsalva complications in her nursing career to take the breathing instructions seriously before she even began. Patricia's readings at week 3 were averaging 149/90. At week 6, they were 140/87. Her cardiologist, who had started from a position of caution, told her at the 6-week appointment that the trend was among the most positive he had seen in a patient with her profile in years. He asked her to walk him through the protocol in detail. She brought printed pages. She said the thing she appreciated most was that she finally understood the mechanism, that she was not following a prescription blindly, that she knew why the burn at 90 seconds was the signal that the protocol was working, why the rest minute mattered as much as the hold, why the 6-week threshold was not arbitrary. She had been a nurse for 3 decades. Understanding the mechanism was not optional for her. It was the condition under which she would trust anything with her heart. Now let me give you the exact protocol, because the execution details matter as much as the mechanism, and one specific mistake can make this dangerous rather than therapeutic. The protocol is called the 4x2 method. 4 holds, 2 minutes each, 1 minute of complete rest between holds. Total time, approximately 10 minutes. For the hands and upper body, a hand grip dynamometer is the clinical tool used in the research trials, a spring-loaded device available at sporting goods stores for under $30. If you do not have one, a tightly rolled bath towel squeezed in the fist works identically. The goal is sustained tension in the forearm and hand muscles, not a crushing grip. For the legs, the modified isometric wall sit is the alternative. Stand with your back flat against a wall, feet stepped forward far enough that your knees are directly above your ankles, not tracking over your toes. Slide your back down the wall until your thighs are at roughly a 45-degree angle, not a full 90. The engagement is in the large muscles of the thigh, the quadriceps, and specifically the vastus medialis. Done correctly, there is zero joint grinding. The knee is not moving. The patella is not under compression. It is an isometric contraction of the muscle around the joint, not a mechanical load on the joint surface. The 30% rule is the most commonly misapplied element of the protocol, and misapplying it in either direction reduces the effectiveness significantly. Too high in intensity and the protocol becomes a strength exercise, which has different mechanisms and different outcomes. Too low, and the metabolic stress never reaches the threshold needed to trigger HIF-1 alpha and the reactive hyperemia response. The sensory guide that works most reliably. Squeeze or hold at the level where you could theoretically maintain the contraction for 5 or 6 minutes if you had to. Not 2 minutes, 5 or 6. That is your 30%. At that effort level, the first 30 seconds will feel almost trivially easy. 45 seconds in, you will notice a warmth beginning in the contracting muscle. By 60 seconds, the warmth has become a distinct, focused burn. By 90 seconds, the burn is significant, and your attention will narrow to managing it. At 2 minutes, you will be genuinely ready for the rest period. If you are shaking at 45 seconds, you started too hard. Reduce by half and start again. If you reach 2 minutes and feel like you could easily go another 2 minutes with no discomfort, you started too easy. Add intensity until the 90-second burn is present and significant. The burn is not pain. It is lactic acid accumulation in the target muscle, the exact metabolic signal that triggers the adenosine buildup and HIF-1 alpha activation. Mild joint discomfort is a signal to check your position. The muscle burn, properly located in the contracting muscle and not in any joint, is the protocol working as designed. The intensity is critical and specific. The effort must be approximately 30% of your maximum possible effort, your maximum voluntary contraction. Not 30% of what feels hard, 30% of your absolute maximum. This should feel very easy for the first 30 seconds. By 90 seconds, it should feel like a deep, localized, uncomfortable burn in the contracting muscle. Not pain, not shaking. A sustained, building burn. If you are shaking or grimacing in the first minute, you are contracting too hard. Reduce the intensity. The goal is precisely calibrated metabolic stress, not maximum effort. Now, the warning that I have to give before anything else. The single most dangerous mistake a senior can make during isometric exercise is holding the breath. It is also the most natural human instinct when a muscle is under sustained tension. The body wants to close the glottis, brace the core, and bear down, a response called the Valsalva maneuver. This is appropriate when lifting a heavy object. It is dangerous during a sustained isometric hold. When you hold your breath during a prolonged contraction, the pressure inside the chest cavity spikes massively. That pressure physically compresses the inferior vena cava, the major vein that returns blood to the right side of the heart. Venous return drops sharply. The heart, suddenly receiving far less incoming blood, sends an emergency signal to the brain, which responds by clamping down the entire vascular system to maintain pressure to the brain. Blood pressure spikes acutely and violently. In a senior with existing cardiovascular disease, this can be genuinely dangerous. I want to tell you specifically what the Valsalva maneuver looks like when it goes wrong in a senior, because understanding the danger concretely is what makes the breathing rule feel non-negotiable rather than procedural. The scenario is this. A senior performs the first hold correctly, breathing throughout. The second hold begins. By 90 seconds, the forearm is burning significantly. The instinct to brace, to hold the breath, to use the whole body to push through the discomfort is powerful. For someone with a history of physical work or athletics, the instinct is especially strong. The body knows how to generate effort. It wants to do what it has always done under exertion. The senior closes their airways slightly, not dramatically, a partial Valsalva. The breath becomes shallow and held rather than continuous. The intrathoracic pressure climbs. The vena cava begins to compress. Venous return to the heart drops. The heart rate spikes in response to reduced filling. Blood pressure surges. In a cardiovascular system that is already managing elevated baseline pressure with medication, an acute Valsalva-induced spike can produce a blood pressure reading that exceeds anything that senior has experienced during normal activity. The treatment for this is not medication. The treatment is releasing the hold and resuming normal breathing immediately. But the prevention is simpler. Make held breath mechanically impossible by forcing exhalation. You cannot close your airway while air is moving out of your body. Pursed lip exhalation, the straw-blowing exhale, makes the Valsalva physically impossible to perform. It is not technique. It is a mechanical override of the instinct to brace. Gerald needed to be told this twice before he truly heard it. He was a man who associated pain and discomfort with effort, and effort with results. The instruction to breathe continuously through the discomfort felt, to him, like being told not to try hard. His cardiologist was direct with him. The breathing is not about effort management. It is about not spiking your blood pressure into a danger zone during a protocol designed to lower it. That framing reached him in a way the first instruction had not. The absolute rule of isometric exercise, the one that cannot be bent. Breathe continuously throughout the hold. Do not pause. Do not hold. Breathe. The simplest way to guarantee this is to exhale through pursed lips, as if you are blowing through a drinking straw, during the most uncomfortable phase of the hold. Forced exhalation makes breath holding physically impossible. If you are exhaling, you are safe. There is one final thing to understand about why this protocol only works if it is done every single day without exception, and it has to do with the biology of nitric oxide itself. Nitric oxide is a gas. The moment it is released by an activated enos enzyme into the bloodstream, it has a biological half-life of under 5 seconds before it degrades and vanishes. It does its work, signals the smooth muscle to relax, and is gone in moments. This means that a single isometric session lowers blood pressure for approximately 2 hours. Then the effect ends because the nitric oxide has degraded and no new signal has been issued. Understanding why 6 weeks specifically, rather than 2 weeks or 3 months, requires understanding the 3 distinct structural changes happening in sequence. In weeks 1 and 2, the primary change is enos upregulation. The daily ischemic stimulus signals the endothelial cells to produce more enos enzymes. More enzymes means more nitric oxide produced with each reactive hyperemia event. Blood pressure begins to trend lower, but variably and inconsistently. This is the phase where seniors measure their blood pressure daily and become frustrated because the readings are not yet predictably lower. In weeks 3 and 4, the autonomic retraining is consolidating. The daily vagus nerve activation is accumulating. The brainstem's baseline sympathetic tone is beginning to drop. Morning readings become more consistently lower. The variability reduces. In weeks 5 and 6, the capillary angiogenesis becomes functionally significant. New vessels are open and carrying blood. The downstream resistance of the vascular grid has structurally decreased. The blood pressure reduction at this point is not dependent on a fresh nitric oxide surge from that morning's session. The architecture of the cardiovascular system has changed. This is what makes the 6-week protocol genuinely different from a daily supplement or a medication. A supplement works while it is in the bloodstream. A medication works while it is pharmacologically active. The 6-week isometric protocol produces changes that persist because they are structural. New vessels, more eNOS enzymes, a retrained autonomic baseline. Not because a compound is present. Permanently lowering resting blood pressure through this protocol requires something different from the nitric oxide surge itself. It requires the body to build more eNOS enzymes, to structurally increase the production capacity of the nitric oxide factory. It requires the capillary angiogenesis to complete and the new vessels to become functional. It requires the brainstem to be retrained through repeated autonomic swings. These structural changes in the cardiovascular system take exactly 6 weeks of daily, unbroken mechanical signaling to produce. The protocol is not something to do when it is convenient. It is a daily mechanical signal sent to the cardiovascular system, the way a medication is a daily chemical signal. Skip a day and the signal is interrupted. 6 weeks. Every day. 10 minutes. Gerald started the protocol on a Tuesday in October. He had been given the 2023 British Journal of Sports Medicine meta-analysis to read, and he had read it the way he read everything, carefully, with a highlighter. He stopped his daily walks that same week on the advice of his doctor, who agreed with the decision given the inflammatory data and the state of his knees. He sat in his recliner with a rolled bath towel and squeezed it for 2 minutes, rested for 1, squeezed again. It took him exactly 11 minutes the first day, including the time it took him to find a comfortable grip. He found it almost insultingly easy. A lifetime of coaching had given him a specific contempt for things that did not feel hard, and squeezing a towel did not feel hard. By 90 seconds of the first hold, his forearm was burning in a way that surprised him. By the end of the second hold, he was breathing through pursed lips and watching the clock with genuine attention. By the end of the fourth hold, he sat back in his recliner and felt something he described later as a warmth moving up through his arm and into his chest. He took his blood pressure 20 minutes after finishing, 144/88. He checked the device twice, assuming it had malfunctioned. That reading was a 2-hour effect, the acute nitric oxide surge. It would not hold. His resting readings the following morning were back to 156/92. But Gerald had been coached himself, years ago, that the first session of any real protocol shows you the ceiling. He wrote 144 in his notebook and started the 6-week count. The day Gerald stopped walking was the first genuinely painful part of the transition. Not physically painful. His knees were relieved within 48 hours in a way he had not expected. Emotionally painful. He had built his identity around physical discipline, and the walking had become, in the 3 years of the blood pressure battle, one of the last physical practices where he felt he was fighting back. Stopping it felt like giving up. His doctor had been direct. The walking was not therapeutic given his joint condition. It was iatrogenic, the medical term for harm caused by treatment. 3 years of doing what he was told had been producing a biochemical environment hostile to the outcome he was pursuing. He sat with that for a few days before he could hear it without resistance. By the end of the first week of the protocol, the ibuprofen was also gone. Without the daily mechanical joint stress, the knee pain dropped substantially. The need for the anti-inflammatory medication that had been silently working against his blood pressure medication for years disappeared along with the cause of the inflammation. 3 variables removed simultaneously. The biochemical load on his cardiovascular system reduced in the first week, in a way that 3 years of walking had never achieved. His cardiologist at the 6-week appointment asked him specifically about the knee pain. Gerald told her it was manageable, for the first time in years. She noted in his chart that the Isometric Protocol had produced blood pressure reduction equivalent to the addition of a second antihypertensive agent, achieved simultaneously with the elimination of the NSAID that had been pharmacologically opposing the first one. At week 3, Gerald's morning readings were averaging 149/88. At week 5, they were averaging 141/85. At 6 weeks, the day he had marked in his calendar, His cardiologist reviewed the log and said something Gerald had not heard in 3 years of walking 3 miles every morning through the pain. She said, "This is genuinely working." His knees, for the first time in years, were not being asked to pay for his blood pressure management, and his blood pressure was finally moving. Here is what to start today. Get a bath towel. Roll it tightly lengthwise until it fits in one hand. That is your equipment. Now, listen. If you have arthritis in your hands and squeezing hurts your knuckles, do not use your hands. The protocol does not care which muscle group you use. If your hands hurt, use your legs. Do the modified wall sit instead. Stand with your back flat against a wall, feet stepped forward so your knees stay directly above your ankles, and slide down to roughly 45 degrees. No joint grinding, no knee pain. And hold for 2 minutes, resting for 4 times. Same mechanism, same result, different muscle. Your joints make the decision about which version you do. Sit in your recliner or a firm chair with your back supported. Set a timer for 2 minutes. Squeeze the towel at approximately 30% of your maximum possible effort. Breathe through pursed lips throughout. When the timer goes off, put the towel down completely. Set a timer for 1 minute. Rest. Then repeat 3 more times. Do this every single day. Not most days, every day. And here is how to make sure you actually do it. Do not try to build a new routine. Stack it onto one you already have. The next time you sit down to watch the morning news or your first program of the day, that is your signal. Towel in hand or back against the wall. The television is already on. You are already sitting. The 10 minutes happen inside something you were already doing. You are not adding a habit. You are inserting a protocol into a habit that already runs without any effort from you. Breathe continuously throughout every hold. This is not a suggestion. It is the single rule that determines whether this is therapeutic or dangerous. Pursed lips, forced exhalation, continuous breath. At your next doctor's appointment, mention the British Journal of Sports Medicine meta-analysis from July 2023. Ask whether the Isometric Protocol is appropriate alongside your current medication regimen. Ask for your blood pressure to be monitored at the 6-week mark specifically. Bring your log. The thing that the 2023 meta-analysis represents is not just a better exercise. It is the correction of a 40-year mismatch between what cardiology was recommending and what the biology of the aging cardiovascular system actually needed. Aerobic walking is an excellent intervention for a 40-year-old with a healthy musculoskeletal system. For a 72-year-old with degraded joints, it is a delivery vehicle for the inflammatory cascade that works against the cardiovascular benefit it is supposed to produce. The research on isometric exercise has been building for over a decade. The 2023 meta-analysis did not discover something new. It established with sufficient statistical power, 270 trials, 15,000 patients, that the existing evidence was definitive. What changes slowly is the clinical recommendation. Cardiologists see patients in 15-minute appointments. The exercise prescription for hypertension has been standard for decades. Changing a standard requires practitioners to have read the recent data and updated their protocols, and that process takes time in every field of medicine. The gap between what the research shows and what the standard recommendation reflects is not a failure of medicine. It is the normal lag of implementation. And the way patients close that gap for themselves is by bringing the research to their appointments and asking the questions that open the conversation. Gerald's cardiologist updated her standard recommendation for seniors with joint disease after his case. Patricia's cardiologist now routinely orders ambulatory blood pressure monitoring alongside the Isometric Protocol for patients with essential hypertension. Individual conversations, initiated by patients who understood the mechanism, changed the practice patterns of 2 cardiologists. That is what this information is for. Share this video with anyone in your life who has been pushing through joint pain to do what their doctor told them was good for their heart. They deserve to know that the research has moved. And if this is the first time the mechanism behind what you are doing actually made sense to you, leave a comment below. I read every one. The protocol is in the description. 10 minutes, every morning. Your cardiovascular system will do the rest.